good. It looks very promising. You have now 92% complete remissions with a single drug, but this is not the only truth, because they have this high complete remission rate. The molecular rate is only 15 to 30%, and we know if they're not in a molecular remission, they will relapse. They have a substantial improvement in life quality, because to eat 4 weeks tablets, it's not too hard. It's partly an outpatient treatment. However, we learned that the relapse rate is very high. And then you have the next step. The first step is to combine your chemo or to give new drugs. So they are also called design drugs. The next is to achieve a hematological or molecular remission. But unfortunately, those patients develop resistance. Either the cells expel the drug efflux, there's a clonal evolution of cells which are independent of the BCR-ABL kinase, or there is a development of BCR-ABL mutations. So it seems that some patients have already resistance in the beginning, then you treat your patients, they respond very well and nice, and then another clone comes up which is not responding to this drug. There are now several big pharmaceutical companies that work all on signal transductors, and they have already the second generation. But this is a fact. So, and also in our elderly patients, you see they have a high rate, 67%, have a mutation, and clearly they relapse because they don't respond to the drug anymore. So I think my vision is the first thing, I'm just talking about leukemia as an example, and leukemia is often a good example because it's easy for you to investigate blood and bone marrow in contrast to your tumors and to follow molecular changes. The first thing is what we had a decade ago, to achieve a complete remission. The next thing is to achieve a molecular remission, but I think the third step is that we investigate the resistance and that we not just give a drug, but that we think already in the beginning whether this drug could cause resistance, because otherwise we deal after 6 or 12 or 24 months with a resistant clone and we do not how to treat. This is a very specific approach because you have to do everything: molecular, remission, minimal residual disease, new drugs, combination with chemo, and determination of the resistance. So I will come to the end. I was also asked vaccination strategies. Unfortunately, there is no vaccination in lymphoma and leukemia, and there is only one attempt about structure. And I think we have here in the room Professor Karlholz. He is one of the discussants. He can tell us in the discussion what the vaccination is really doing. And I personally think, so this is how we improve the acute lymphoblastic leukemia. These are the children. They cure now 80%, but I'm often on pediatric meetings. It's extremely hard for them to come above the 80%. You know, you have to do, they do already everything. But for the elderly patients, we have a big potential because we have now these biological approaches, antibody treatment, new drugs, tyrosine kinase inhibitor. I have shown an example, and I think by intelligent combination, we may soon, or we are on the way to cure 15% of adults. When I started this multicenter trial, the cure rate was 80%. So I thank you for your attention. And the last slide is the topics which were raised by the organizers, which should be discussed now in our round. Do novel strategies replace classic? I doubt. I think it's a combination. We still have to work with chemo. Cellular therapy, standard treatment, I think that's different from your... we have, for this kind of leukemias, we have huge national trials in Britain, in France, in Germany, everywhere, one large trial. They have different approaches, so there is no standard. And if we would have an evidence-based standard, it would be on a very low level. Therefore, I cannot present evidence levels. And I touched the topic number 5, resistance mechanism. But I think this is a very good basis for the discussion. Thank you very much for your attention.